We're next going to look at the pituitary hormones. So if you remember, the endocrine system is really controlled by an area in the brain called the hypothalamus. And so it's going to secrete releasing and inhibiting hormones that are going to go by a portal system right to the pituitary gland and bind to receptors there. And as those hormones released by the hypothalamus bind to receptors in the pituitary, they're going to tell the pituitary to either secrete or not to secrete its hormones that can then um, influence many of the different types of endocrine organs we have in the body. The anterior pituitary releases many hormones, and we call them tropic hormones. These hormones are going to be proteins that will be released that can then travel through the bloodstream. The pituitary gland, because it controls all the endocrine organs, is called the master gland, and it is in the brain. There are two areas of the pituitary gland, the anterior and posterior lobe. And if you remember from anatomy, the anterior lobe is very similar to the mucosa that makes the oral cavity. And the posterior lobe is really closer to nervous tissue in nature. And so the anterior lobe um, is going to be involved in making and secreting these tropic hormones. So if we look, here are our tropic hormones that are released by the anterior pituitary gland. And we can see that they have multiple different targets for different types of actions. And at the very top of our diagram here is the hypothalamus. And if you remember, that's the way the nervous system is going to be able to interact and control the endocrine system. The pituitary hormones, these tropic hormones, they're actually administered for different ailments, and they're administered parenterally, so intramuscularly, subcutaneously, or even intranasally. And the reason is because they cannot be taken orally because the digestive system, the gastric proteases and enzymes would break them down. So we're going to start to look at some of these. So the first is adrenocorticotropic hormone, or ACTH. And this gets released by our anterior pituitary. So we're going to talk more about this pathway actually in depth because cortisol, it's called a glucocorticoid, is a huge drug class. And we prescribe it for many different things. So we'll be looking at this pathway in more detail in a lecture to come. But what's interesting, ACTH, its release follows, we call it a diurnal rhythm. It follows day-night cycles. So we actually have a peak of this hormone in our bloodstream around 6 a.m. in the morning. And the pathway works as negative feedback, as does many of these hypothalamus, pituitary, endocrine organs do. So what happens is the hypothalamus releases corticotropic releasing hormone that travels to the anterior pituitary. We're going to have the release of our ACTH. That's going to travel through the bloodstream to our adrenal gland, and the adrenal cortex here is then going to produce and make cortisol, and that's the hormone that it releases. And in the body, cortisol has anti-inflammatory effects. It helps to increase gluconeogenesis, to raise blood glucose levels, and it increases protein breakdown. And the reason why it does those things is, remember, cortisol is a stress hormone, so odds are the sympathetic nervous system is upregulated, and these are the things that we need to be able to have the energy to, as we say, run for your life when the sympathetic nervous system is upregulated. There are reasons to give ACTH. It's used in diagnostics with Addison disease or what we call secondary adrenal insufficiency. What we can do if we don't think that the adrenal gland is producing cortisol, we can give an injection of ACTH and then measure the cortisol levels to see if the organ is working properly. We also use it to treat multiple sclerosis because if we can increase cortisol, that acts as an immunosuppressant um, on the immune system. And then infantile spasm or West syndrome, what we think is going on there is that's a severe type of epilepsy. And we think ACTH might mediate potentiation of nerve growth promoting activity. The next hormone is growth hormone or somatotropin. So, growth hormone regulates the growth of many, many different organ tissues. And here again, the release of it occurs in a pulsatile manner, and the highest amounts get released during sleep. So, if you've heard that saying with kids, like, oh, you grew overnight, well, that's where this saying is coming from, in a way. The growth hormone spikes at night. And so it stimulates cartilage, bone, muscle, and fat. And what it does is it works to put nutrients into the bloodstream like glucose. It breaks down fats and proteins so that those are going to be there and available to help tissues to grow. If we look here again, it's going to work by a negative feedback mechanism, but hypothalamus will release our growth hormone or releasing hormone, which travels to our anterior pituitary, which will release the growth hormone. And then that will be available to come to the muscle and bones for growth and repair. It'll go to the liver. In the liver, we're going to have production of what we call IGF-1. Same thing in the bone and soft tissues, they'll release IGF-1. IGF-1 is for insulin growth factor 1, and that's a mitogen. It tells cells to grow and divide. You can see we'll also have the breakdown of fat and gluconeogenesis so that we can have nutrients and building blocks put into the bloodstream and to be able and to utilize for the cell division. The growth hormone itself then is going to go back to the hypothalamus, and we'll have our releasing hormone, somatostatin, released, and that's the negative shutoff. So it will turn off the release of growth hormone. So what we see is that people who have a lack of growth hormone, that can result in dwarfism. You can see that here, so it's a shorter than normal stature. If there's excess growth hormone, two things can happen. In children, we see what we call giantism, where there'll be extreme height. You can see in this picture, this man just towers over the car in the background. In adults, if there's excess growth hormone, it results in something called acromegaly. And here we have appositional bone growth. So our bones widen instead of lengthening. And so it's most predominant on the face and the long bones like in the hand. So if you look at this young woman, you can see how her chin is elongating, becoming square. We have, as she ages, widening of those facial bones and fingers. So therapeutic uses. So somatotropin is the growth hormone. We can give that to children who have growth hormone deficiency or failure to help them to grow. We also do use it for wasting syndrome. So patients, for instance, who have HIV/AIDS, where they cannot gain weight and are having issues with weight loss, or if adults have short bowel syndrome and they cannot absorb nutrients properly. Short bowel syndrome is where there's malabsorption because um, a large component of the small intestine it's either missing or has been surgically removed. As well, we can give somatostatin. So somatostatin, um, remember that's the inhibitor, so it stops growth hormone from being released. And we can use that then to treat acromegaly. So some people have abused growth hormone, and it is against the law to prescribe it for reasons outside of the indications um, given. Um, in the 1990s, people were taking growth hormone for athletic performance, and also adults were taking it because they thought that it had anti-aging properties, since it does help to increase muscle mass, and so it's been touted as like the anti-aging cure. There's a couple issues with that. So in 1990, they did do a study where they gave males over 60 years old growth hormone, and it did increase muscle mass and decrease adipose tissue, which is beneficial. So it did seem to improve, for instance, athletic performance. However, some developed diabetes. Another issue with taking it outside of the prescribed conditions is that it does release insulin like growth factor 1, that IGF-1, and that causes cells to divide. So as we all age, we have more precancerous cells, and so one of the issues then is that it could potentiate cancers in adults. Our next group of drugs are the gonadotropin releasing hormones, and LH and FSH. And so hopefully you remember a little bit about these from anatomy. So gonadotropin releasing hormone originates in the hypothalamus, and it travels to our anterior pituitary, where it releases FSH and LH. And so remember, the FSH is for follicular stimulating hormone, and LH is for luteinizing hormone. And those names are coming from structures in the female reproductive tract, but both males and females produce these hormones. And so once FSH and LH are in the bloodstream in the female, they're going to help to regulate ovulation, and in the male, sperm production. And so we can make analogs that would bind to our gonadotropin releasing hormone receptors. And we prescribe these for things like prostate cancer. If it is hormone responsive, that means that it will grow in the presence of androgens, or for endometriosis, or for children who are undergoing precocious puberty, which is puberty that can occur very, very early in a child's life, and not at the proper time for males or females. How these work is that we basically put more of the hormone in the system, right? So it binds as an agonist to the receptor, and it causes desensitization of those receptors. So eventually, what will happen is the body will stop producing its own FSH and LH, and so we'll have less of it secreted. So in the male, then we will have less androgens, in the female, less estrogen and progesterone produced. These are not without side effects, of course. So in females, when we give these, we see an increase of like hot flashes and sweating, decreased depression, decreased libido, depression, sometimes ovarian cysts. In males, they can cause initially an increase in testosterone, but then they can also experience hot flashes, bone pain, edema, gynecomastia, which is an enlargement of breasts, and also decreased libido. So the LH and FSH, so luteinizing hormone and follicular stimulating hormone, these regulate the gonadal steroid hormones. So that's the androgens and estrogen and progesterone. So those made by the testes and then the ovaries. And so these can also, the FSH and LH, they can be used as fertility treatments because they do regulate the gonadosteroid release. So in males, H for human, CG for the chorionic gonadotropin, um, it's related to LH. And so it can cause sexual maturation of organs. The HMG for human menopausal gonadotropins is related to FSH, and that can trigger spermatogenesis or the creation of sperm. In females, the FSH or HMG can cause follicular growth and maturation. So if you remember, the follicle in the ovary is what contains the oocytes. So if we have more follicles grow and mature, then a number of them would be available for ovulation. And then the HCG can actually trigger ovulation because that's related to the luteinizing hormone. And so we use these a lot for patients who are having trouble to conceive or if they have to undergo in vitro fertilization, because now we can harvest many follicles or increase spermatogenesis. Now, the posterior pituitary, remember, it's a different tissue. It works a little bit differently, but it does secrete its own hormones. So one of them is oxytocin. In the female, oxytocin helps to trigger uterine contractions, and it is also utilized in the milk letdown reflex for breastfeeding mothers. So we can give artificial oxytocin, which is called Pitocin, and that triggers uterine contractions. So if a female is not going into labor or it's not progressing, we can give Pitocin to start to trigger stronger uterine contractions. Vasopressin is also released by the posterior pituitary lobe, and that's the same as ADH. It's more commonly known as ADH, so antidiuretic hormone. And this treats diabetes insipidus or cardiac arrest. So diabetes insipidus, it's a rare disorder, and it occurs when a person's kidneys pass an abnormally large amount of urine. And because it's a large volume, it's very dilute and odorless, which is where the name is coming from. So in most people, the kidneys pass about 1 to 2 quarts of urine a day. But somebody who has diabetes insipidus, they can pass between 3 to 20 quarts. And so the person has a need to urinate quite a bit, but then also they're very, very thirsty because they have to drink large amount of liquids to replace that fluid loss.